You'll learn a lot, except for the two people trying to help you understand what it is we're learning today. Okay, I'm seeing the numbers kind of holding steady here. So why don't we kick off? Again, thank you for joining us. My name is George Huntley. I'm the CEO of the Diabetes Patient Advocacy Coalition. Really happy to be with you today. In my other day job, I'm also the CFO of a health plan, of a professional services firm, and I have been the plan administrator of a health plan for 20 some years. So I'm delighted to be with you, and my good friend Stuart Perry, who is chair of the Diabetes Leadership Council. And Stuart, why don't you say a few things about your minor background, and you know a little bit something about insurance?
No. What's your next question? My name is Stuart Perry, and I serve on the board of DPAC and was formerly vice chair. As George said, I'm chairperson of the Diabetes Leadership Council. And I am an insurance agent, a State Farm insurance agent by profession. And I also, by doing that, I am an employer and the administrator of my small group plan for my employees, which is only about 5 of my 12 employees qualify. So I have to deal with that. And while George deals with it on a much larger scale, I'm dealing with it on a very small scale. But George, they didn't tune in to hear about you and me. So Let's talk about what we're going to do today.
That's a great idea. So what we're going to do today is we'll demystify the different types of health insurance. So by the time we're done this quick half hour, and it may go a little long, we'll see, you'll understand what it is, what these acronyms mean. We're going to talk about special considerations people with diabetes have when choosing a health plan, and there's a tool that we will share that will help you do the math. Jacob's going to make sure that link is available to folks. There's a spreadsheet that, for those that really love math, that you can download that'll help you walk you through some of the issues to get to the math. So why don't we get to the math?
So George, how do you choose the right plan? I mean, when you say do the math, what do you mean?
Well, it's math. So you want to know your total cost, right? So in understanding that, we all know what a premium is. We all know what a deductible is. It's not the premium. It's not the deductible. It's not the cost sharing alone. It's the total cost. Any one of those buckets or circles there are important, but it's the far right-hand circle that's the most important. You got to know all of them. It's not just the premium. It's not just the deductible. It's what's your all-in cost. And that's what will tell you whether you've got the most cost-effective plan for you.
So George, everybody knows what premium is because we all either have it deducted from our check or we have to write a check or use a credit card for it. Can you kind of break down premium and deductible for us just a little bit?
Absolutely. Absolutely. So the premium is the amount you pay for your health coverage. It's the entrance fee for the privilege of joining the plan. It's like you joined Sam's Club and you're paying Sam's Club, and this gets you access to the network. And we're going to talk about next, Cigna, Aetna, Blue Cross, that gets you access to it. Now you're paying this premium if you're employed through your paycheck, right? So that's typically coming out of your paycheck on a pre-tax basis. If you are not employed or you're buying it through the exchanges, then you're writing a check to the insurance plan for the privilege of being in the plan. Now the deductible is how much you have to pay out of pocket before any of those premiums mean anything to you. So you've got to pay that amount out of pocket before any of the coverage and the healthcare services in the plan begin to kick in. So knowing what that deductible is kind of important, but it's also important to know what's exempt from the deductible. Because in some cases, there could be some things that are exempt from the deductible, like insulin can be exempt. Wellness visits typically are exempt from the deductible, things like that. So when you think about what's your cost going to be, understanding if that plan has exempted it from the deductible, or is it part of that number that you need to pay.
And then drugs?
Drugs absolutely can be part of the deductible. And it may, in today's world, it typically is. In some cases, it's a separate deductible for drugs. And in a high deductible health plan, which we'll talk about in a minute, it's a combined deductible. So understand if you do have a separate deductible for drugs, you need to be aware of that.
Okay, George. So HMO, PPO, EPO, HDHP, RAGGMOPP, RAGMOP. What do all these things mean?
We got to talk about cost sharing.
Oh, I'm sorry. You're right. I was trying to go past that because cost sharing is about as mystifying to an individual that tries to get their health care covered as anything. So talk about it, and then we'll go on to the other thing.
The alphabet soup. So cost sharing is actually one of the hardest parts of this. So, when you think about your premium and your deductible and your, those two, those are really easy to understand what those numbers are. The cost sharing part is what you owe after your deductible's over, right? So you know what your deductible is. So that's a finite number. I can do that math. I know what my premium is. I can do that math. What do I owe once I've met my deductible? And that is typically a copayment, like in your drugs, you $35 copay. It can be a coinsurance, which would be calculated on a percentage of the amount that's due. And many times in the major medical, you go to see your doctor, you go have a procedure done. Sometimes you owe 20 or 30% of that procedure. So it could be a percentage. And you pay that cost sharing after that deductible up until you've met your out-of-pocket limit. And that out-of-pocket limit is an important number because after that, you stop paying and the insurance pays all of it. So in 2023, that maximum, that out-of-pocket limit is $9,100 for individuals. That's a big number, but at least it's there. It's capped. So it's important that you understand what you're going to have to owe after the deductible's over and the insurance itself kicks in. And it's those three variables together that equals your total cost. It's just math, guys.
Yeah, I got to tell you, George, we've already gotten it confused. So, all right, so let's go on and talk about the type of plans.
Okay, so this is alphabet soup. We've got high deductible health plans. We've got preferred provider organizations. We've got exclusive provider organizations. We have health maintenance organizations. This is not where you get your personal oil change done. But these are the names of plan types. And we're going to talk briefly about what all that means.
Yeah. Can we break this down a little bit? Because most people, and I as you know, George, I've been licensed to sell health insurance for almost 39 years. It still mystifies me sometimes.
So what these plans mean, and we're gonna separate high deductible health plans because high deductible health plans can honestly be any of these first three. When we talk about preferred provider, health maintenance organizations, or exclusive providers, a high deductible plan can be any one of those three. But what they typically mean is how broad or narrow your provider network is, whether your doctors are in there, right? And then is there a gatekeeper and how much of that cost is going to fall on you and the plan? So that then those letters that that plan design, that structure means something. So a PPO is the most open plan that's out there. You do not have to go through a primary care provider. You don't need your primary care provider in order to go see a specialist. That's an important thing because in an HMO, you absolutely have to go through your primary care person before you see anybody. If you got an ingrown toenail, you got to see the primary care person before you can go to the podiatrist. These are things that may or may not mean something to you. With diabetes, do you need a referral to go see your endocrinologist? You just might. So these are important things. Out of network coverage is another very important thing. In a PPO, it's going to be more expensive. So when you say more expensive, you talk about a 70-30 plan or an 80-20 plan. That 70-30, that 20 or the 30 there is your co-share, that co-insurance part, going back to that cost sharing in the slide before. But if you go out and network, that number is a lot higher. You're going to owe a lot more as a percentage for having seen a doctor, gone to a hospital outside of that network. Now, if you're in an HMO or an EPO, you could find yourself not covered at all. So if you go outside of the network, it's because you were traveling and you had an accident. And in that case, you're covered. But if you've gone to see a doctor in your town that's not in your network and you've got an HMO or an EPO, you could be SOL. That's another acronym that we're not going to cover.
And it could be higher than the 30 and 20% you just talked about, George.
Substantially.
I've got one in front of me here that's actually 50% if you're outside a network. So you gotta be careful. All right. So high deductible health plans. The reason they were formed was to supposedly reduce the cost of health insurance. But the problem is that's when pharmacy got stuck into deductibles and the copays rather than the $10 and $25 that we used to know. So should people get high deductible health plans to reduce their healthcare costs?
Well, the answer is maybe. So you go back to your total cost. Okay. So if you have to go through the math. Again, premium's easy, deductible's easy. Cost share is the part that you got to think about. So in a high deductible health plan, the deductible is a higher number. Okay, don't get afraid of that, but work the problem, do the math. In this scenario, you're going to have to pay $1,500 as a minimum. To be a high deductible health plan, the minimum deductible is $1,500. So you know it's going to be a fairly large deductible. As you mentioned before, it includes drugs. So your drugs and your doctor visits, hospital lab work, and all of that is part of is subject to the deductible. There are things that are outside of the deductible, which are things like wellness visits, sick baby, well baby care, those kinds of things. But for a person with diabetes, our general care, most of that's going to be part of the deductible. So understanding what that is, what a high deductible health plan gives you, and we're going to talk about this at the end, but I'm going to tease it now. It gives you access to a health savings account that could save you money. So typically in a high deductible health plan, you're going to have a lower premium and you're going to have access to a tax deferred way of paying for some of these costs. So why don't we continue on and touch on these later, but the message here is do the math.
I was going to say, George, but in most high deductible plans, they're not $1,500. They're $2,000, $3,000, $5,000. So let's talk about PPOs real quick. Pros and cons.
Yeah. So as discussed, typically lower deductible, not always. You got to look at the plan. May have no pharmacy deductible. That's one of the unique things about a PPO. You may not have a drug deductible, or it may be separate and therefore much lower. Often has a lower overall cost exposure to the consumer, to us, and it's usually the broadest network out there with few referrals. The con is you pay for it. So you got to, again, it's about total math. It's not about one variable being higher than the other. It's about what's the total all-in cost. And, in some cases, again, access to your doctors is a big deal, and you're most likely going to have access to your doctors through a PPO.
But not always. But George, as we move on to HMOs, PPOs is what most people have, isn't it?
Well, PPO is a very common scenario, yes. In a high deductible plans, a lot of them have a similar scenario of a PPO. Yes, I would agree with that. Yep.
Let's go on to HMOs.
So an HMO are going to have a lower premium because it's a narrower network. All right. And in an HMO, you've got to go to the doctors in that network. It is a narrower network. It's typically not a very broad national kind of thing. There's a gatekeeper before you can access any specialized care. But in an HMO, you may actually have lower out-of-pocket costs for chronic diseases. They actually are trying to help you maintain your health. That is what that plan design is about. But it's really about the narrow network and giving you a gatekeeper to jump through before you get to the next one. If you go outside of the network, expect to pay 100%.
Nice. So what's the difference between an HMO and an EPO?
So an EPO has the first two, no, it's not just the first two letters in the O before the O, but it's an EPO does not have a gatekeeper. So the simple thing about an EPO is it does not force you necessarily to go through your gatekeeper and your primary care provider before you go see a specialist. But man, those networks are very, very, very narrow. And you pay a lower premium. And again, you can't go out of network. So you get a savings if your doctors are in this kind of plan or your doctors are in the HMO, you can save money by being in that cycle and in that kind of a structure. But your doctors need to be in there because those networks are substantially narrower.
Okay, so let's go back to high deductible health plans again. You've talked about a lot of this stuff, but let's talk about the cons.
All right, so the cons of a high deductible health plan is it's super high. All right. And to your point, it's 1,500 minimum. Many of them are up to $5,000. Okay. So you've got to have the cash flow to be able to afford that out of pocket before your insurance kicks in. So, your January through April, you could be spending a lot of money out of pocket. So if you got the cash reserves for it, by December, you could be fine. But if you're having trouble making ends meet and paying the rent, this may not be the kind of plan for you. Pharmacy is included by law. It becomes challenging from a cost and a cash flow perspective. The one thing I will touch on, because I don't think we've got it coming next, is in a high deductible health plan, you get access to a health savings account, which is in that's what the HSA is there. An HSA allows you to put your out-of-pocket costs, you're talking about your cost sharing and your deductible period stuff, and pay for that pre-tax. So you could be saving money by whatever your tax bracket is. If you're in a 30% tax bracket, you can be saving that. You're saving 30% off of your out-of-pocket costs, and you can put thousands and thousands away into an HSA. And you in a PPO without a high deductible plan, you can use a flexible spending account. Does the same thing, same principles. Flexible spending accounts are use it or lose it. HSAs is your money, it rolls over.
So George, let me interrupt you just a second. Yeah. I have type 2 diabetes. My HSA, and I fund the maximum. I go through it every year. Is it still a good deal?
So the short answer to that is it's a good deal because you're getting a tax savings for everything you put in there. So okay. If you spent $4,000 in your HSA and you burned through every bit of it, people with diabetes are going to. We have a lot of out-of-pocket costs. Then we're going to have to. You're going to get a benefit of that because you saved whatever your tax bill would have been on that money. So if you're 30% tax bracket and you put $3,000 on it, math's not my strength, but you saved about $1,000. So that's a win.
Okay. So while this is the disclaimer, we are not tax experts. We're not giving tax advice. Please contact your accountant for your own personal information on this issue. George, let's talk about Medicare. Well,
before we do, we've got a question that is on here. The government is raising the low end of the high deductible plans for 2023. So basically, the amount of your deductible is getting batched up. The reason provided is inflation. Why is inflation a reason to hike the deductible? This is impacting on patients. You're right. What groups are behind these hikes? How dare they? And why do they keep raising that number? And also, most jobs have zero choice. You're quite correct. Some high deductible with cost sharing seems to be the norm. So how do we change that? That's hard to change. Why they get raised is that these are insurance products that insurance companies are underwriting, et cetera. And in order to have the insurance company take the risk and be required to take the risk, I'm not defending them at all. I'm just saying why you're seeing it this way. The insurance company wants the inflation factor on that deductible so that their risk stays commensurate with the economic cycle that we're in. And that's why the deductibles and things like that are increasing with inflation. That's a normal thing, and that's nothing you can do about it. And you're right, many employers, we offer high deductible plans. We also offer PPOs, and you price them accordingly. Many employers will only offer you a high deductible plan. There's not a lot you can do about that if that's what your employer is doing, except perhaps lobby your HR people. and maybe find a different employer. I know that's really easy for me to say and hard for people to do, but people do change jobs because of their health plans, because a health plan is a retention and an attraction tool for an employer. We use that in my company as such. So I wanted to answer that question, but now we're going to shift a little bit here because we build this as both commercial plans and Medicare. So we've got a couple things I want to touch on in this to do some speed dating on Medicare. ABCs. So the first question is, what's all this ABC stuff? So we're moving quick here. Part A and B is in and outpatient. Very simple to think about. Things you need to be aware of is the bottom of this page here, talking about when do you enroll? Because we're talking right now in October, because open enrollment sessions period is starting for everybody. Most corporations will kick in their open enrollment in October or November. Social Security, or really Medicare, starts right now. I think October is the month. This is when you can make changes to your plan, okay? And if you're in Medicare and you're already enrolled and you don't want to change anything, it's just going to automatically change for you. If you're, however, in a plan that you've purchased that's outside of Medicare, that's like a Part C, which we're going to talk to you in a minute, you may have to annually renew this. So this is your time to renew and do this. If you are just turning 65, enroll immediately, unless you are covered in an employer plan. You can pay a premium, a penalty, for every year you decide, I don't need Medicare right now. I'm covered under my spouse's plan. I'm covered under something like that. Be very careful. When you do enroll, if you don't enroll during a special enrollment period, you can be nailed with a 10% penalty. So if you worked 5 years past your age 65, you could literally be paying 50% more if you don't be careful about when you time your entry into Medicare. So people need to be aware of that. Go ahead, Jacob. Drugs and donuts, aren't that exciting? So the donut hole, in theory was closed by the Affordable Care Act and ended last year. The problem is it really didn't totally end, because most people are in a plan where you have a deductible and then you have coverage, and that coverage is typically like a copay. You're paying $35. When you hit in 2022, $4,430, now you've moved from a copay to co-insurance. Now, the good news is the co-insurance is 25%, whereas before the Affordable Care Act and some of those things that tapered it out, it was 100% and people were going crazy. But it's still, you're at 25%, which is going to be typically higher than the copay you were paying before that. The max is $7,400 in 2023 for that out-of-pocket for drugs alone. But the good news is the Inflation Reduction Act that was just passed will drop that to $2,000 in 2025. So that's really good news for seniors, but it's not in 2023, it's not in 2024. So you got to get through 2 more years before that comes in to help you.
So, George, let's talk about Medicare Advantage and Medicare policies. And I know a little bit about this. I am older than you, by the way. So, and talk about them real quickly. The Medicare Advantage basically takes over, and Medicare does not look at your claims. Basically, this is a health insurance policy for people who are Medicare eligible. You enroll, and then you turn around and you tell it so that do a Medicare Advantage. It's like buying health insurance instead of Medicare, and doing what's on the next slide, which is Medigap policies. So basically, there are certain, you've got financial thresholds on here. There are certain things in here. Many plans will have Part D, which is drugs. Many don't. So let's go on, Jacob, to the Medigap, and we'll talk about both of them.
Before you jump off of this, the thing that I will highlight is you are now buying private insurance to replace Medicare. And it can be a PPO, it can be an HMO. You're back into all the things we just touched on. And so think about you're buying regular insurance, and it may have dental, hearing, and vision coverages as well. That's why people go to Medicare Advantage.
And as we go to the next slide, George, my mother-in-law did this, and she comes out much better on the Medicare Advantage than buying a Medigap and the regular Medicare. Medigap is very simple. There are letters for that from A to G to J. All of them, the higher letter you get, the more it covers, the more it costs. Medigap policies are to cover the gaps in Medicare to put you back to where you're not out of pocket. You got to look hard, you got to look fast, and you got to do the math on these just like you do on private health insurance or your group insurance, because they're not they are individual. You don't get to put spouses on, and the monthly premiums all based on which plan you selected. So get an expert. There is a whole book that is published by the government on these things and what to do that you ought to get and follow. And every company that tries to sell you one of these is required by the government to get you that book. So the big thing, George, and I know you probably want to talk about this slide for 20 more minutes, but the big thing on it is do the math and plan, right? Because when do you not plan?
You don't plan in a crisis. That's a bad idea, to plan in a crisis. Isn't that a great? That's a great picture.
So, George, as we, when you go to buy a car, you look at sticker shock. That's where the term comes from. What do you recommend to people?
So know before you go. So read the summary benefits and coverage. They're required to give it to you. Understand, are your docs in these plans or aren't they, right? Are they covering the same products, your insulin pumps, your insulin pens, the CGMs? Are your items covered in these things? You got to look at the documents to do it. You got to do the math. As we just talked about Medigap and all the Medicare, premiums, which we didn't say in the first. In Medicare, you can have 3 different premiums you're adding up, and 3 different deductibles that you're adding up. So it makes it a little bit more complicated, but the fundamentals of premiums plus deductibles plus cost share equals your total cost. It is no more fancy than that. You just have to identify all the parts. And we actually have a spreadsheet, which we are not going to go into right now, that will, if you have diabetes, specifically type 1, you're on insulin, and you can load in what your deductible is, what your premiums are, how much you're paying for insulin, and it will help you walk through the math to compare different plans. So if we hit the info at diabetespack.org, and we can get you that. Hopefully the link will be up there shortly as well.
George, let's talk about claims.
Well, insurance companies are built around the word no. That's the first word that they're taught. They take weeks and weeks of training when a new hire comes into an insurance company. You've been through this. You've done this for your whole life. You tell me no all the time. But when you get a no as a patient, appeal it. Don't take it for granted. Just appeal it. They are counting on you to give up. They have 72 hours to respond to your appeal. Call in HR, call in reinforcements, call in, be a squeaky wheel. The squeaky wheel gets the grease, the squeaky wheel gets the no reversed. If you're getting a no, don't just take it lying down.
And George, the one thing you left off is you get more flies and bees with honey than you do with vinegar. So be nice, but be insistent and persistent. And as the man said, never give up, never give up, never give up, never give up. I'm waiting for Jacob to move the slide. Never get up, never give up. Okay? Never give up. That's why the Allies won World War II, and that's what you should do with your claim, because a no today could very well be a yes as you get pushed up the pipeline. So, George, where do people get help if they need help with their insurance, if they need help figuring out what's going on?
So first, if you're having trouble affording your insulin, please hit that code that's on the screen right now, and we'll get this thing. Also hit the DPAC website and the Diabetes Leadership website. There's an insurance cost worksheet. Getinsulin.org is a great place to walk through all of your options for insulin in particular. There's a number of information of sites out here to help you understand how to choose the right health plan. Hopefully today whetted your appetite for this. And it sounds daunting. It's not as daunting as if you just work yourself through each pieces of the math on this, and you'll get to the answer that's right for you. I know we're at the bottom of the hour here, and it's time. We do appreciate.
If you've got your phone, George, before you go there, if you've got your phone, take a picture of this slide.
Yeah.
This has all of these are great resources, as well as a resource that we're not going to get to today, but George has done on doing the math. So, these don't just deal in the dark. Shine a light on this stuff.
Yeah, it's doable. And lastly, guys, thank you so much for being with us today. We appreciate your spending your lunch hour with us. Hopefully we haven't made you lose your appetite in doing it. Hey, we would really welcome and appreciate your joining the DPAC Army. We advocate on behalf of people with diabetes. It's what we do. If you take a picture there with your phone and click through to that code, you can become a DPAC champion. You will get alerts from us when there's a topic of interest, a piece of legislation at the federal or state level. Maybe it's a petition to the Federal Trade Commission on pharmacy benefit managers. These are things that we've done within the last few months. We are active out there, and we're here to help amplify your voice. So if you want to have your voice in this and be part of us, we would welcome it. We're not in competition with anybody else. So if you're an advocate at JDRF, if you're an advocate for ADA, great, join us too. And if you're an advocate for us and you're not an advocate for JDRF and ADA, join them too. We all go after, and we work in concert in the advocacy world. Be an advocate, make your voice count. It does matter. Thank you for being here today. We really appreciate your time and your attention, and we wish you nothing but good health and strong insurance coverage.